Okay, you can start.
Okay. Good evening, everybody. I am Dia Bashetti, and I'll be moderating today's session along with Ananya Joshi and Naushil Moladina. Thank you for showing interest in this webinar on obstetric violence by MSFC unit of AMSA. Obstetric violence is a specific type of violation of women's rights in medical practice during healthcare related to the childbirth processes. Ill treatments and abuses during labor creates a psychological distance between the women and healthcare providers, driving women away from formal healthcare systems in fear of being subjected to such violence, and sometimes are a more prominent hindrance than geographical or financial barriers to maternal health service utilization. Despite this fact, obstetric violence is also an often overlooked type of obstacle to quality maternal healthcare service utilization as compared to other barriers. Therefore, today we have Dr. Kaveri Myra, who is the speaker for today's webinar. Dr. Kaveri Myra is a midwifery, nursing, and global health researcher from India with a PhD in global health from the University of Southampton, UK, where she explored the experiences and determinants of obstetric violence in India through an Artspace method called birth mapping. She has extensive research experience on nursing and midwifery workforce, policies, regulation, and practice, sexual, reproductive, and maternal healthcare, and the underlying gender-based challenges. Dr. Myra was recently recognized as one of the 100 outstanding global midwife and nurse leaders by Women in Global Health, WHO, ICN, ICM, Nursing Now, and UNFPA to mark the Year of the Nurse and the Midwife 2020. Dr. Myra is currently working as a subject matter expert with the WHO headquarters to create the essential respectful care course for the global midwifery community. Thank you, ma'am, for joining us today. At the end of the webinar, ma'am will answer questions from the audience. So if you have any questions, you can drop them in the chat box, or you can raise your hands and then unmute yourself and ask the question. You can all switch on your cameras if you're comfortable with it. Ma'am, you can go ahead.
Thank you so much. Welcome, everyone. I'm going to quickly share my screen. I'm allowed to do that, right? Right. Are you able to see my screen?
Yes, ma'am.
All right. Thank you so much for the introduction and the opportunity to talk to what I have been told are all medical students in the audience today. I can't see you at the moment because, well, technology only lets us do things up to a limit. But sessions on obstetric violence are usually a little sensitive in nature, and I usually set out a disclaimer that the content that you will be hearing today is very sensitive, and it can trigger incidents of violence that you may have seen, you may have witnessed, you may have experienced. And the thing about obstetric violence and respectful maternity care is you absolutely need to make sure you take care of your own mental health. So at any point, if you feel that this content is not something you would want to stay on, or you would like to take a break, or you feel this is too triggering, just take a step back, leave the session if you want, come back and ask for a recording for it, or talk to a friend. Do whatever you feel you need to do to take care of your mental health first. I will be talking about breaking the silence around obstetric violence in India. It's part of research that I have been doing over the last little over a decade or so in India and in other parts of the world. And I'm currently based in Southampton, UK. I'm in between finishing a chapter of my life, which is my PhD, and starting a postdoc, which will happen soon. I will request you to keep your audios muted for the course. And if you have anything urgent to say, please do put it in the chat box, and I hope somebody will pick it up. With that, I think it's just a minor question that I want to ask first and foremost, and that is whether obstetric violence exists in India. Like, do you think it exists in India? And I'm going to put the chat on the side. If you could just say yes or no to this, that would be great. I'm going to wait for like 30 seconds. I just want to get like a quick sense of what you think. Right. Anybody who's writing like a few more S's next to their yes, I'm guessing they have seen it way too much. And that's for the emphasis. Well, thank you so much. I will be asking a few questions during the course. So this is good to know that this is working. Well, I agree with you. And I think obstetric violence exists in India. At least I have seen it quite a bit. You are seeing a slide on evidence of obstetric violence in India. And I will not be reading out any of these. But because this is being recorded, I think you will have a sense of what all research I'm trying to show. But these are just a few states where there is evidence, and there is evidence coming in different forms of publications, presentations, every year, every month. This is just formal published research, as we researchers tend to reference. But there's way more than what you're seeing. And some of this work, especially in West Bengal and in Bihar, is work that I have been deeply involved in. So that sets the stage that, yes, obstetric violence definitely exists in India, but it's not just something that's an Indian problem. While this is not an extensive kind of review, but the countries you're seeing turned red are the countries from where I have personally read evidence in different forms of obstetric violence. Having said that, it doesn't mean that the problem doesn't exist in countries which are not turned red. It's just I have not read evidence yet. I think somebody saying something. Sorry, should I go ahead? I hear somebody saying something.
Yes, ma'am, go ahead.
Yes, ma'am, you can go ahead.
Right. Basically, not just that particular slide, which shows you that this is a global problem, but this slide shows a campaign. It was called What Women Want, and it was a global campaign which went around in 114 countries. And around 1.2 million women and girls were asked what their one demand is for quality reproductive and maternal health care. And with an overwhelming number of responses, over 10% women with the top demand was for respectful and dignified care. And you will see that people, women who give birth, often they find it very difficult to share that they have experienced obstetric violence or mistreated or have experienced disrespect and abuse, but rather it's easier to say that, well, care could have been more respectful. So that gives you a little idea of how big this problem is and how difficult this challenge is, because particularly it's happening in healthcare facilities by people like you and me who are educated, who are part of and responsible to provide care to these people who are coming to us seeking care. Now, that was about whether obstetric violence exists in India, but this is more personal. I want to know whether you have ever witnessed obstetric violence, and you don't have to give any detail, but just tell me a yes or no if you have seen. And you may not still know exactly what obstetric violence is, but something that you saw happening during sexual, reproductive, maternal, or even neonatal care provision, and you felt, no, this is not right. Okay, I'm seeing a lot of people saying yes. From the names, I'm seeing a lot of girls and women saying yes. Are there men in the audience? Oh, I see one person. I hope more people, especially men, will answer too. I'm seeing 4 or 5 yeses to this. So I'm guessing others have not then? Well, I will tell you about an incident that I observed, and that kind of set the story straight for me. And given you are students, I think it's only appropriate that I share a story of obstetric violence from when I was a student. Can I request everyone to please put your microphones on mute? Yes, please just make sure that your audios are muted. Right, so this is a story from 2007 or 8 when I was a midwifery and nursing student. And this is in India, this is in West Bengal in a tertiary level government college of nursing where I was a 3rd year student, and that's where maternal and reproductive healthcare provision comes in. And as a student, we used to have to assist childbirths in this very busy labor room. I'm pretty sure you would have heard of labor rooms. And this one time, while I had seen obstetric violence day in, day out, and every day I was observing it, but this particular incident kind of stands out because that is where I kind of took a stand and felt like, okay, I can't just go on with what I'm seeing. So what happened is, and the content is a little sensitive, so I'm really sorry about the language. I'm trying to keep it as raw as it was. So basically, the woman who I was caring for, she was called by a doctor to do a vaginal examination. And while there is terrible lack of privacy in government hospitals, especially at tertiary level in general, with like 3-4 labor tables, but there was this examination area where you could put the curtain on, but generally people will just come in and they will not see if somebody is exposed inside, and they will not ask for consent, or they will not ask for permission, as is seen in these government hospitals particularly. And I repeatedly say that because that's where I have learned and practiced. So I was there and I had kept the person covered and helped her to climb up on this like really tall table, and I was standing at her head end. And this doctor, I think he was on a phone, and he just comes in a hurry. He puts one hand, he gloves up, and then without any explanation or anything to the woman, he just goes and lifts his sari and her sari and petticoat with his elbow. He just pushes it away and just rushes in to do a vaginal examination. And just before doing it, he just stops and he says, "Whoa, how does your husband want to do anything with you with that jungle you have grown there?" And this was one of the most extreme kind of cases that I had seen. And I kind of freeze when I hear that, because I had seen other ways, but this was just too on the face, too extreme, and too, I would say, intentional. And I don't see any reaction on the woman's face. She just turns her head, tries to cover it with her pallu or something. But I go very blank. And there are a couple of other people as well. Somebody who came to take a signature from him, and another senior nurse. And she sees my face, and I was just blank. And she just says, "Oh, the doctor is just joking." And this is considered a joke when a woman is clearly being sexually abused. This is verbal abuse as well. This is a lack of privacy as well. And this is something called a poor rapport with the care seeker, and also terribly, inhuman an experience. So what I do is I try to take it up and I report it to the senior authority against this person, but nothing much happens. In fact, I was told by my seniors later that, "Well, Kaveri, what you saw is absolutely not a practice that should happen or should encouraged. But what you need to learn from this is that you should not engage in this kind of a behavior when you are practicing in future." So that's what I needed to learn. No repercussions happened to the doctor who engaged in that practice. But yeah, that is what happens when you take a stand. But I went ahead, and in the rest of my career, I kind of took it as a challenge. I not only did research, I did campaigning, I do a lot of writing, I did a PhD on it, and that is where life kind of set off to try to address this issue. But having said that, trying to understand obstetric violence is also something that we need to approach from our positionality. And the reason you're seeing a weird picture of me balancing myself on a rock is because I'm going to talk about positionality, and do look it up what positionality is. It basically helps you understand where you're coming from. Like if you see a problem, why do you see it as a problem? Like why do some of us feel something very strongly about an incident in college or on the streets, and others don't? And often who we are, what our privilege is, how we are conditioned, how we are brought up, what our value systems are, they have a lot to do with why something is a problem to us that stands out and why it doesn't to others. And positionality could begin with simple things like, for me, I am in my mid-30s. I am an educated person. I have just finished my PhD. I am divorced. I have never given birth. And those things kind of become specific about this, because talking about childbirth, it's important to understand that I have never given birth. I have tocophobia, which is a fear of birth, which I think developed from seeing obstetric violence so much in my life. But think about it and write it down, write down positionality, and think about who you are, how that impacts you as a person, about an issue you are looking at, about things that you discuss, about things that have an impact on you, and see where you come from, and it will answer a lot of things about why. And you will see why I'm making you do this later. So now that you have heard one of my stories of obstetric violence, I was wondering if you would like to share an incident of obstetric violence. Now, think about it, and it doesn't just happen when somebody's given birth. It can happen when you're seeking, sexual health care or reproductive health care, seeking care for abortion, or have just gone because you have a question that you want to ask. It can happen in neonatal care as well. I had texted in a group asking you to share these incidents. So if you have written something down and if you want to put it in the chat box, do it right now. And if you feel that you would like to share it later over the course, please do that. I'm not going to stop for that, because I just really feel like it's a good exercise to write down an incident that bothered you about obstetric violence that came up, and would be good to in fact find somebody to talk about it as well, but see whether they feel as strongly about it, what they think about it as well. So remember to do that in your time. So following that incident, I kind of started doing research around it. And there was this one incident, this one research that I did on husband as birth companion. And this is around the time when, even though in India, having husband during care is not that usual a practice, but I used to see it in a lot of Western movies that partners and husbands and boyfriends, they are there when a person is giving birth, and that looks like something of tremendous emotional support. So I did a research on that, and while I was looking at other things, a major thing that stood out was that women perceive that having a birth companion may even reduce disrespect and abuse during childbirth. In fact, some of them even said that if they saw them giving birth and understand how much pain and effort they go through, that might even reduce domestic violence. So I think now that I'm into telling you about things about obstetric violence, let's get a little bit of theory out of the way. And I will try to not focus too much on definitions, and I will just indicate some of these resources so you can have a look at it later, and I'll leave time for us to talk about it more in the end. There are many definitions about obstetric violence, but it comes under different terminologies. There is something called disrespect and abuse. It could be called dehumanized care. It could be called mistreatment during care, misbehavior. And this particular one is from actually a research team set in Bangalore. And this particular definition is one of my favorites because it actually includes a lot of the things, and it will answer some of your questions about why obstetric violence happens in the first place. So what Sen and team says about obstetric violence is, in the context of obstetric care, we define disrespect as the violation of women's dignity as a person and as a human being on the basis of her economic status, gender, caste, race, ethnicity, marital status, disability, sexual orientation, or gender identity. Now, disrespect is often revealed in a biased normative judgment that health workers make about women and from resulting acts of omission or commission. But abuse is actually more extreme, and it refers to actions that increase risk of harm to women and are not in best of interest of her health or well-being. So to give you a quick example, disrespect can be just, saying, like passing a verbal comment about somebody's physical appearance or education or the number of children they have. Or abuse could be hitting somebody, pinching somebody, raping, and many other different forms of violence. If you are interested about what the different forms of violence there can be, there is a particular paper by Megan Bohren and team, which came out in 2014. Do have a look at that, and I will put it in the chat later. While this particular definition tells you about why it happens and different things that can have an impact on somebody, whether this person might be abused or not, there is another one with Friedman's team, which talks about how violence is not always individual. Like when we think about obstetric violence, we often think that the healthcare provider slapped the person who is giving birth because she was screaming, and that is violence. Yes, that is absolutely violence, but it doesn't just end there. There are individual forms of violence, like the one I just told you. There are also structural forms of violence. Now, if there are, say, 4 labor tables in a labor room, and there is no privacy, there is no curtain, there is no screen, there's no way to protect privacy of women who are giving birth from each other, from their birth companions, then that's not intentional, and that is not something that the care provider intended to do. It's a lack of resources. And there can be many such things that can lead to obstetric violence, and this is one type. And finally, there is something of a policy level. So if, for example, there is a unit which has 1 doctor and 2 nurses, and the caseload is very high, and people are finding it very difficult to provide care to all these women in 3 shifts, they are genuinely under a lot of workload, and often a lot of things will slip by. They will not be able to maintain privacy as much. They will not be able to spend as much time with each person as they should and provide every kind of care that they are expected to. So now that is a policy level change. That is a change in human resources that needs to happen at a policy level in the state or at the central level, so that there are more people in the facility, they can spend more time, they can go through everybody's challenges and issues and ensure more of a respectful care and surrounding as possible. There are other definitions as well that I will not get into today. But having said that, I feel it's important to talk about respectful maternity care as well, which is like the antidote of obstetric violence. And this is a WHO definition that I'm going to keep here for a bit, but not read because there is a lot of content to cover. But do check out what respectful maternity care WHO definition is. And there are WHO's intrapartum guidelines, which came out in 2018. There are, I think, 56 recommendations, and 4 of them are new, which are particularly on respectful maternity care to ensure a positive birthing experience for women and people who give birth. Now that you know what this problem is about and have an idea of what it looks like, why are we discussing about it? Why should it matter? I think the main answer to that is because obstetric violence is a violation of a woman's human rights. And a few years ago, 3 years ago, I was interning at the WHO headquarters in Geneva, and I came across the Universal Declaration of Human Rights. Not that I didn't know about it before, but this was important because I took this tiny booklet and I just wanted to see what exactly the articles are under which we can say that this is a violation of human rights. And these are the 6 articles that I thought are being violated when a woman, a person experiences obstetric violence. There are also other reasons, like it can lead to postnatal depression. It can leave a person feeling raped, and this can be seen in women's narratives who have experienced obstetric violence, who say things like, I felt stripped off, I felt forcibly exposed, I felt my sexual organs were put on display. You will also find, in fact, particular such incidents or words or phrases in our local languages on how women explain this. This, what I'm writing, is coming from mostly UK and intense writing and extensive writing on it. Somebody is their mother and need to put their audio off, please. Thank you. It can also increase elective cesarean section. I'm pretty sure you would have heard a lot of people seeing this and going around and saying, I'm not going to experience this. I would rather go for an elective cesarean section. And this could be just to avoid the humiliation during childbirth. Tocophobia is the fear of childbirth, something that I experience. And there are many other reasons as well. Now, I'm showing you a picture that you have seen before, and I want to look at this person for a second and tell me in the chat if you think this person is experiencing obstetric violence. And if you can, if you quickly say one thing that you feel is violating. I'm going to give you 30 seconds to do that. You can just say yes, or you can say yes and add something that you're seeing that is bothering you in this picture. Or if you feel that she's not experiencing, and if you see something very respectful, you can say that too. Absolutely, privacy is violated. You can see a lot of people standing around this, exactly, too many people. What else are we seeing apart from privacy, now that privacy has been taken up? Or is there a different form of privacy that you're being violated other than just the people who are here?
Yeah, the
Right?
face.
I can understand about lithotomy position, but having said that, do people think lithotomy is the best position to give birth, particularly for normal birth? Think about it. There are a lot of positions which are genuinely way more helpful and positive than making the woman lie down and be all hovering on her. So do some thinking about lithotomy position, definitely. So yes, we know the privacy is definitely being violated, but think of a few other things. There is somebody who's cringing their face a little bit. There are people peeping from the door who have no business to be there. There is a very, very tough maneuver that is happening here. We called it fundal pressure. That is also quite a form of physical violence. Then there is, you can see, this is actually artery forceps we have tried to make here, and she's being pinched with that. So that is a terrible form of obstetric violence as well. Plus, how exposed she is with bare minimum ways to maintain her privacy, as you have all found out. Now, I, in my PhD, went around and asked some people, healthcare providers, to see, mainly nursing and midwifery leaders, to see what are these factors that are making these women vulnerable to experience obstetric violence. And these are some of these reasons that came up. I'm going to only focus on the women's side. You're seeing the nurse midwife side as well. And you will see a lot of these things like teen culture, over medicalization, lack of supervision, hierarchy, which kind of are on the care provider's side. Many of this, I'm pretty sure, stand true for medical students as well, because hierarchy plays, and the lack of, or the imbalances in power dynamics plays a key role in why obstetric violence happens. And I'm pretty sure as medical students also, you are at a particular position in that medical hierarchy that makes you vulnerable to be bullied, to have a kind of workload that others don't experience, or to have a kind of working condition that others don't feel. But also it's important to be mindful that there are others who are probably more disadvantaged than you. But when we think about the woman, it could be her age. She could be giving birth when she's not even 20. She could be giving birth when she's above 40, and that's why she is experiencing this. It could be because she's a woman. It could be because she's a religious minority, because she's not educated enough or is highly educated. So she knows too much, and people do not want to get into that. Personal hygiene, physical appearance is an issue. Medical status can be an issue. And also in a larger scale, it could be that in some facilities, culture of abuse is a particular way of giving care to women. That can be a reason. It could be about the perception of birth in the community, like, how somebody can feel that women so young shouldn't be giving birth, or women so old shouldn't be giving birth, unmarried women shouldn't be giving birth. So those kind of norms around it, or discrimination in general against women, or discrimination against a newborn female. There could be cultural myths and norms which could be, encouraging this. So think about what are these things that you feel exist at your personal level, or you feel exist in your healthcare facility. Like, I remember there was this healthcare facility I had come across where everybody was forced to get a PPI-UCD, and they were not even asked, because this is close to an urban slum, and women are not that educated, and they will just be asked that, they will at max be told that we are inserting IUCD because you have too many children, or that kind of a thing. That is abusive. Lack of consent in any form or way is abusive. So yeah, so think about all these things and what such reasons are at different levels from where you stand. I have a tendency of asking people about their birthing experiences, and I have had that since I was a student. But it's not always easy to ask those questions, because narrating stories of childbirth is as sensitive as narrating stories of abuse. And I used to go around and ask people, okay, if you can't say it, because it's quite shameful as well to talk about birth, because it involves talking about genital areas, about body parts which we usually don't discuss about. So I came up with something called body mapping, and this is how it evolved, because I couldn't record their experiences on my body. So I started drawing a picture, and I will start asking them about, okay, what happened? Did you receive fundal pressure? Did you get an episiotomy cut? Did you not receive anesthesia when you were given episiotomy, or when you were being sutured? And it kind of developed into something that is quite extensive and shows a person's experience through art-based research methods. I will not go into the details of the method, but just to know that how somebody gives birth, what somebody expects from birth, why birth is good for them or bad for them, is very different. It's very diverse, and it comes from how somebody is conditioned, how somebody is brought up, what these value systems are. And for everybody, those are different. So it's very, very important to listen to women, to people, ask them questions, give them an opportunity to ask them questions, and understand what kind of care they expect, so you can provide that kind of care. Now, this is a little bit about the way of body mapping that I did. As you can see, there were a lot of arts-based methods, and I did it in Bihar with 8 women, 4 in rural areas and 4 in urban areas. And this is the I think centerpiece of my PhD. And these are a few of those body maps that you are seeing. And I'm just showing you a little bit about what these women's backgrounds are. But as you can see, there are different kinds of abuses that are happening, but there are different things that are respectful as well. But to go into the detail, I will read out two things. One is a respectful care quote from Amrita, and Amrita is a pseudonym that I have used. And this was in Hindi, I have translated. But this is what Amrita said when I asked her what is respectful care to you. And she said, care should be like when I told them what problem I have, they should come and check me completely and tell me about my condition, that in how much time I will deliver. I will feel respectful when they will do my delivery on time without delay, when they will speak with me politely with a smile, when they will take care of me nicely, if they gave me a bed. They should treat us like family members, no matter whether I'm birthing a boy or a girl. I should be treated well. They should talk to me nicely, no matter whether it is nurse, doctor, or dai. They should give immunization, injection, medicines, and other supplies from hospital. When we will share our good experience with other women in the neighborhood, that we are not disrespected there and people are not greedy, what's the point of going there otherwise? So now that you have heard about respectful care from one of these women, I'm showing you something called an I poem. Now, this is a way of analyzing these women's stories, where you filter out some of these narratives where she starts by saying I or my or me. And this is about a particular incident. And as you can see, there's a title of it as well. The lady doctor was really nice. And I'm going to read this out. And just to let you know that this is, again, a very sensitive anecdote. So Urmila's I poem, Urmila says, I told her not to do it, but she forced her hand in me. I told her, don't put your hand in because it was hurting, but they continued to do so. Didn't listen to me. I was so angry with the doctor because she called me so many times for vaginal checkups. Every time she told me the passage did not open. I didn't like it. I was shouting and crying due to pain, but still the doctor kept on suturing. I asked them for behoshi ki dawa, but they did not listen to me and kept doing it. I thought my problems are over after giving birth, but the real challenge was post-birth. I was screaming, the doctor and sisters were holding me down from all sides and kept stitching me. I felt all of it. I kept screaming and asking for anesthesia. I felt all of it. I didn't have such pain in my first delivery while stitching. I liked the behavior of my doctor and one of the nurses. I didn't like those two frowning sisters who shouted at me. There's another way of understanding these women's stories. It's called birthing story. This is a birth map of Pero, but this is quite a long story. And this was co-written by Pero and me, where we brought down and kind of summarized what she told me over like a whole week. And while I'm not going to read it, it basically tells you everything about what she experienced, and it says things about her two childbirths. It says about her perception of why she experienced that she experienced. It's a story of a cesarean section. As you can see, she was blindfolded and she was given spinal anesthesia, and she was never informed that she's going to have a cesarean section. She found out she is going to have a surgery after her leg started going numb on the operation table, and she was blindfolded before everything happened, so she will not get scared. It's quite a difficult story, but if you read it later, you will see a holistic picture of why this is happening and why this is so important an issue to tackle and address from Pero's story. So do have a read later. What I'm more interested in doing today is to understand what you could do if you were in a situation of obstetric violence unfolding around you. And I will go into, like I haven't done this before. Like I haven't gotten into talking to people about, what can you do? It's usually about what my research has dealt with so far. And this is not something I have gotten into yet. But you have seen all this. And if you could, again, give in a couple of responses on what you think you could have done in one of these situations, or probably you would have done. I would really like to read before I go into some of the things that I thought through. I'm giving you 30 seconds to do that. Anybody? Informing the woman about the process is important, absolutely. I think a lot happens from awareness, because a lot of the times you'll be surprised to hear that some of these abuses that you and I look at as obstetric violence, women find them quite a part of normal routine care. They feel that it is expected. They expect to be abused. They feel the doctor, the nurse, the midwife, the other people who are providing care, with a health background or not, they're doing it because they need to discipline them, and they need to, they're doing it for their good. They think it's a part of quality care. Another one is intervene. Absolutely, intervening is very important, and try to explain the abuser why what they are doing is wrong. Absolutely. While this is very important, we also need to be mindful that the people who are engaging in this kind of abuse are healthcare providers like us. So definitely think about how will you address this situation. Play this scenario, form a group or something, do like a role play. Somebody becomes an abuser, somebody is giving birth, and then somebody is thrown into that situation. That what are you going to do now? Are you going to just tell your friend like, hey, are you having a bad day? Are you going to just be like, hey, deep breaths? Are you just going to be like, okay, why don't we go outside and talk this through? How are you going to do that? And I think one important thing about taking a stand of intervening is way difficult to do than to say. And there are quite a bit of repercussions. I think why we don't generally take a stand is because we haven't seen, like, nobody role models taking a stand. Like, I never came across like so much obstetric violence around me. I never saw one person like the clinical instructors or a midwifery professor or a senior doctor or a nursing superintendent, head of the department. I never saw one person taking a stand and being like, listen, don't do this. And I think if we saw our teachers taking a stand and stopping a behavior like this, it makes it more normal for us to understand what exactly stepping in is. Prenatal education and how they can address this situation, absolutely. Make them aware of their rights, of what's right, about consent, about birth companion, of birthing positions, all you can tell. And tell them about how they can file a grievance. Where can they go if they do experience something like that? Tell professionals involved to stick to better practices. If you're not in a position to take a stand, contact whoever is responsible. Ethics department, that's a major step. There has to be proper set guidelines about what are the ethics and norms of care. And while I say that, we all know that our education begins with do no harm, but how at some point we as care providers start indulging in a practice like this is something that we should all think about, because we shouldn't forget that even though we are not constantly being taught about be respectful, we are usually respectful in general with people around us in our regular lives and people we talk to in our conversations. Then what happens that when we are trying to give care to somebody in a vulnerable situation, we behave like that. So I'm going to go to this slide now, which is about what can you do about it. And some of you have given excellent responses. And I was doing like a bit of a brainstorming on my own. And this is what I have written. I have written take a stand, which you have said. I have written about reading. And by reading, I mean, there is enough like scientific research around it on what you can do about it. Inform yourself about the issue, the challenge, what's happening with it. Mental health is important. Usually, things around trauma and things around abuse, there is a lot to do about understanding your own mental health of the people who are abusing, mental health of people who are being abused. Mindfulness is something amazing that I have experienced. Try it out. Campaign, start something small in your healthcare division, in your university, in your college, with your own society, association. Start something to just raise awareness that this is an issue and what should we do about it. Share experiences of respectful care that you would have seen. It can't just be obstetric violence. You probably would have seen something nice somebody did or you did that made you feel very good, or you experienced obstetric violence, you saw obstetric violence, and you did something to make the person who's experiencing a little better. Discuss these things. There's something called story completion. Google it. It's basically you start a situation like so many different scenarios that things could have been dealt with rather than how it practice empathy. By that I mean be respectful in general and take lessons from your own life. And how do you talk to people? How the conversation happens that you have with your professor, with a nursing superintendent, with a nursing student, with the midwifery student. In general, people who are in group D, people who are who
Ma'am,
are guarding facility.
I'm sorry to interrupt. Actually, hello, ma'am. Your voice was breaking.
Can you hear me now?
Yes.
Sorry. Did you hear me on the last slide?
No, I don't think so.
Okay, so I'm going to keep this slide on for a second. You can take screenshots if you want. And then I think if you have any questions, do reach out to me personally. But some of the examples you will see as I go in. And I think the most important point is to listen to these people. I think we provide a lot of respectful care just when we listen to these women, what they're trying to say. We often don't give them enough time. But if you just stay there and listen to what problem they have, what question they have, show some interest, there'll be a lot that you will be able to learn from them. The things that I was telling you, these are some of the things that I did. It
Ma'am,
includes, sorry,
ma'am,
yes.
unable to
Can you,
see your screen.
sorry, you're not able to see my screen?
No, ma'am.
What about now?
Yes, ma'am. Okay. Thank you, ma'am.
Okay, so I was giving examples about writing. I was giving examples about scientific writing, about conference presentations, about campaigning and activism. And if you want, there is a journal club that I run. It's on Twitter. So do write down the Twitter handle. And I talk about different journals that are publishing on obstetric violence and papers in there. I also run a book club, which is called the Birth and Body Book Club, which is not just about obstetric violence, but about respectful care, about bodies, about birthing, about sexuality, about everything in that gamut. With that, while I think I have tried to answer some of the questions I got from your list, if there is any other question that you feel I can answer, please let me know. I'm going to stop sharing this now so I can see you. Over to the moderator.
Thank you, ma'am. I hope you all enjoyed this amazing presentation. Now, I will be answering some questions. So if you have any questions, please unmute yourself and ask the question. You may raise your hand for that. or you may drop the question in the chat box. So any questions?
Excuse me, I have a question about this entire thing. First of all, thank you for the talk. Really, really illuminating, and I feel fortunate to have understood this in a more complete sense. Uh, I have my question is in two parts really. What can we do on a policy level? Because I did some research before coming here, and it seems that in private hospitals, obstetric violence is much lower than in government hospitals. And what that makes me feel is that in India, particularly, government employees are not beholden to their patients in the same way employees at private enterprises are. And maybe this is just an Indian problem, I don't know. But the thing is that in every single government institution that you go, there is not even any sort of basic human decency. You go to a bank, you go to get your voter ID card. There is no basic human decency, which is actually there more in these private enterprises. So my first question really is, maybe getting the government out of the healthcare system might help this. My second point really is it's personal to me. I don't know, but is there really an epidemic of women, especially from lower socioeconomic backgrounds, who are afraid to actually go to hospitals to give birth, despite the significant dangers of giving birth at home? Because my own maid, despite me asking her to come to my college hospital for her daughter's birth, she refused, and she had her daughter give birth at home. And it, I kept encouraging her to come to my hospital, and I'll take her through the things and help. I offer to do that, but the fear is so palpable. And is this really an epidemic, is my question.
Sorry, I'm not very sure on. Okay, let me answer your first point about what can be done at the policy level. A lot can be done at the policy level, not just in terms of policy guidelines, but also in terms of legal ways. Like the whole thing about obstetric violence kind of started. It became a legal terminology, I think, in South America for the first time. And as of now, there are at least 5 countries in South America which has laws against obstetric violence. Look into it. Argentina, Mexico, I think Chile as well. And there is a lot happening in Europe as well. I think Spain is considering it. I'm not entirely sure. But yes, I think legal measures is something that is a way out. But having said that, given the perpetrators are healthcare providers, mainly, it makes it more muddy a situation to deal with, right? I mean, it's not domestic violence, it's not any other form of sexual violence where the perpetrator is not like a heavily educated individual and probably the most honored or looked up to professional in the community. So yes, absolutely, there should be also a no tolerance policy. As I mean, we say these no tolerance policies very easily, but what exactly does that mean? Who will not tolerate it? Because usually the abuser is the person with the highest power, and then it kind of trickles back, and that everybody kind of becomes kind of an abuser. But yes, I think while there has to be policies about absolutely no tolerance, but there has to be other things as well. We need to be able to understand what exactly the problems are in the facility, and not everything is going to look like a direct answer to obstetric violence. Like I said, human resource shortages is an issue. You need to think about those that will address a lot of other challenges as well, and address this issue as well. The thing about infrastructure, the thing about making your birthing environment so which is respectful, thinking through that what is happening, doing a proper kind of auditing of the environment. What are the things that are not respectful? I mean, putting yourself in that woman's position and thinking that, will you give birth here? If not, what are the different reasons? Just do like brainstorming again. Because birth here.
Excuse me, ma'am.
Sorry, did I get dropped out again?
Yes, ma'am. We were unable to hear you. Just for the 1 minute.
Okay, so yeah, so that's what I was saying, that you need to put yourself in that situation to see what are the things that makes you not want to give birth. I had once done that as well. I had kind of written a blog about all the reasons I don't want to give birth in the facility where I learned how to assist childbirths. It's just to see the different things that you can address. Many of those you will be able to address at your level, and not they don't need to be done at a policy level. And the ones you think can be addressed as a policy level, take it up as a unit. I mean, you have thousands of members, don't you? If you put up a letter saying these are the things that are making women's lives vulnerable, they don't want to come give birth here because this is what happened, with that story that you just shared, I think it will draw people's attention and you will be an ally in ensuring respectful care. Yeah.
Yeah,
Does
thank you, ma'am.
that, any other questions?
Ma'am, so this is one of the questions we had received. How do we prevent cases of obstetric violence in situations where we are not in position of power, such as when we as students observe a senior or professor mistreat a patient?
Yeah, I mean, you have heard what I did and the reaction I got, which is not very encouraging. But I will tell you that, I mean, the day this happened, I had gone to my college library, and I had my best friend with me, and I had narrated this whole incident to her. And I just kept telling her, nothing is going to change. I mean, who is going to listen to us? We are nursing students. I mean, you are at least medical students, right? So in the power hierarchy, I was below where you are now. But having raised my voice, I knew nothing was going to happen. So my brilliant idea was, me and my best friend, we were both deciding this, like, hum logo ko PhD karna padega. Like, we absolutely have to do a PhD, otherwise nobody is going to listen to us. Like, there is no weight in my voice, there is no weight in what I'm trying to say, the issue I'm trying to raise. So yeah, so that's what I did about it. I did a PhD 15 years later. But you have to find smaller ways and bigger ways. See what you can do in short term, and see what you can do in long term. What does the research say? Is there research that is not being done? I'm not sure if research is in the medical curriculum, and if there is, well, no, answer that. Is research in medical curriculum? Are you supposed to do a research in your? You are, right? So think about areas that you would like to explore. What is the research that exists, and what is it that you would like to take up? Some of you definitely, and do get in touch with me if you want to brainstorm about it. Other ways, see some of these, and share it with somebody. You have case discussions, right? So let this be a case and raise it up to somebody, take it to your professor, and just ask them. Sometimes, just asking people, of this is a situation you faced, this is making you uncomfortable, what could you have done? You will find different kind of answers from your peers. You will see different kind of answer from your professors as well. And like I said, there is so much you can do by just reading and writing, by making people aware, and by changing your own behavior. I think we often find this in others, but we don't reflect on our own behavior. Tell somebody to guard yourself. Like, I'm seeing two people here, Dia and AMSA India. I'm sorry, I don't know what your name is, but I'm going to call you AMSA India. AMSA India and Dia will be each other's guards, and you're practicing together. In the course of the day, if Dia sees anything in your behavior that she feels was objectionable, she will tell you, and that's because you asked her to do it. you tell her that, यहाँ पे थोड़ा temper ज़्यादा हो गया. This is, you could have probably said this more respectfully, or you could have, shouldn't have lost temper there, or you should have probably listened something, or you probably didn't see she was trying to call you. Or you called somebody with the bed number instead of calling somebody with their name. You didn't say a hello. There can be so many of these little things that you can address in each other's behavior and see if there's a difference by end of a month. Only then can we think of, addressing someone else's behavior, because then you would have practiced it in yourself, right? There is no straightforward answer to any of these. As
Ma'am? I think you're we got
versus many things are not
many
informed.
things are not.
I'm not sure. I'm not sure how this question is relevant, honestly. There is a serious shortage of nurses, I agree. And while I can go on that, like I said, it's one of those HRH issues, and there is a shortage of other healthcare and non-healthcare staff as well. And it's not just the nurses' responsibility to inform properly. I think doctors play a key role in informing people as well. So yeah, I'm not entirely sure of what to answer. I mean, definitely there is a particular ratio of what needs to be maintained, and we just don't have kind of workforce. I'm sorry, I'm not seeing a connection of that with obstetric violence other than that. I do see another question: has Lakshya program actually helped? And I will take that. So I'm not aware of any Lakshya evaluations that have taken place. If you have, do point me in that direction. But yeah, I mean, Lakshya, I think, came out in the end, at the beginning of 2018. So it's been 3-4 years. Having said that, I am a big believer that Lakshya could have had more stronger content on respectful maternity care. I think some of these things, I remember seeing a table in Lakshya which talks about, privacy should be maintained, a birth companion should be provided, talk to people respectfully, those kind of things. And I think some of these things are pretty straightforward. Is there anybody who didn't know in the audience that you're not supposed to, that you're supposed to maintain privacy, that you're supposed to, behave respectfully? So I think it goes way beyond that, and I think it's a tricky subject area. It needs a lot of conceptualization, a lot of deliberation and understanding and conversation around it to bring out something that actually makes sense. So I wouldn't have hoped a lot from Lakshya, especially in terms of respectful maternity care. And I believe just saying privacy maintain karo is not enough. We all know that. How do we do that? What is the responsibility of the person who's providing care? What is the responsibility in the structure? What are the indicators to show that we have resources? What is being done at the policy level to ensure privacy? So those are different levels of things that we need to see. Right, anything else?
Ma'am, I think we can close the Q&A session. We have reached our time limit. So thank you again, ma'am, for answering those questions and for the great presentation. It was a pleasure to have you with us. I think it was a real eye-opener session for all of us on this topic since it's not discussed. So this concludes the webinar. Thank you all for attending, and we hope you have learned and enjoyed this presentation. Thank you.
Thank you so much.